Better? Okay.
Present.
Director Garza?
Present.
Director Guggenheim? Director Guggenheim? Director
She's
Guggenheim
present.
is present. Director Harrington is absent. Director Kim is absent. Director Ketting?
Present.
Director Munar?
Present.
Director Prendergast?
Present.
Director Ryder?
Here.
Director Story? Chair Taylor?
Present.
And circling back to Director Guggenheim, we see that you're present, but if you could acknowledge the presence.
Yes, present. Sorry, I went back in the kitchen to get my coffee.
Okay. Thank you. You have a quorum.
Pursuant to the Illinois Open Meetings Act, meetings held remotely.
Sir, we can't hear. Lyndon, if you were just saying something.
Yeah. And I'm getting weird feedback.
All right, we would ask everyone who's not speaking to mute themselves, please. Can you hear me now?
Way better.
It's better, but it's still low.
We're working on it. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. The streamline will combine the action items into a combined motion. Meetings of the CCH board and its commissioners will be held remotely until otherwise noticed due to the determination that a public health emergency exists. To begin the meeting, I'd like to acknowledge that on April 27th, 2022, Cermak Health Services suffered the loss of a dedicated correctional professional. Mental health specialist Jennifer Hamilton's life was tragically taken too early. She dedicated herself to the mental health advocacy, but perhaps her most important legacy, we believe, is a positive impact she made on all of her colleagues and friends, a great way of supporting and helping others. Today, she is remembered and grieved by the Cermak family and the entire Cook County Health family. I would ask you that we take a moment of silence to honor her. Thank you. The next regular meeting of the board will be held on Friday, May 27th at 9 a.m. The first item on today's agenda is employee recognition, which I believe will be handled by Ms. Valerie Amos.
Morning, everyone. This is Valerie Amos, Chief Human Resources Officer. Today, I'm honored to recognize Joyce Ogonti, a nurse in the Stroger Hospital Emergency Department, who was awarded Judge Emma Shannon Walser Medal for Rule of Law, Good Governance, and Patriotism from the Liberian Institute for Growing Patriotism for founding the ACRES, which stands for Alfred and Colonette Reynes Everybody Served Community Clinic in Millsburg, Liberia. Ms. Ogonti and her husband founded ACRES Community Clinic in 2013 in honor of her parents in her hometown of Millsburg. The clinic provides free medical care to residents, most often treating patients suffering from malaria, heart conditions, pneumonia, gastrointestinal diseases, arthritis, and more. Since opening ACRES Community Clinic has served more than 88,000 people. Ms. Ogonti's passion for caring for people in need stretches far beyond Cook County, and we celebrate her efforts to improve the health of those in her Liberian community. Please join me in welcoming and congratulating Joyce Agunti. Ms. Agunti, did you have words?
Yes, well, thank you. All protocol observed. I'd like to thank you all for this opportunity in recognizing me. What I do is not for this recognition, but is to help my people, the less fortunate, and to be recognized in this manner. I say I am humbly pleased. I couldn't do this by myself with all the help of many of my friends, my co-county families, individually as well as collectively, my church, Morgan Park Pentecostal Church, the University of Chicago Hospital, among many others. And I enjoy the work that I do, and my ardent desire is to continue to help my people in Millsburg and pray that God grants me the strength to continue this work. Again, I'd like to say thank you for this great honor.
Absolutely. Thank you for your service.
Good morning.
Ms. Amos?
So we'd like to recognize Dr. Ashley Winfield, who has been named Cook County Health Doctor of the Year for 2022. Dr. Winfield is an emergency medicine physician and assistant program director for the Cook County Health Simulation Laboratory or Simulation Center. In this role, she educates not only emergency medicine residents in Simulation Center, but also residents, fellows, faculty from all departments across CCH. She created and leads the Emergency Medicine's Diversity, Equity, and Inclusion Committee, spearheading meaningful developments to make Cook County Health more inclusive and welcoming environment for both patients and staff. She serves as a mentor for all students, all ages, from high school through residency. As one nominator wrote, Dr. Winfield is a personification of the Cook County Health mission. Dr. Winfield graduated from Tulane University and earned her medical degree from Louisiana State University Health Science Center at New Orleans. She completed her residency at Cook County Health and a simulation fellowship at Cook County Health and Rush University. And I would say that this award is voted on by all members of the staff of Cook County Health, not just the physicians. As our 2022 Physician of the Year, I hope you'll welcome and acknowledge Ashley Winfield. We're very proud of you. Thank you.
Just wanted to say thanks. This means a lot. I have just very few short words. I was reading the email, and it talked about sort of a commitment or a personification of the county mission. And I tried to kind of think about a little bit about what that meant. And I think I wasn't born here. I'm from Louisiana, but I was born at a similar health, similar facility at what we call the charity hospital system in Louisiana. Just sort of my lived experiences growing up, I identify very much with the current struggles of our patients. Things were tough. You didn't always know what you were going to eat, if the lights were going to be on. And I can see many of the barriers and access to care that our patients sort of experience. And so I find that my whole goal and the whole reason why I came here as a resident and why I've stayed on as faculty is that continued mission and the fact that Cook County allows me to take care of those patients. and not have to worry about their ability to pay. And so I'm extremely grateful to this hospital system. And then lastly, I know that we've been making some strides forward, but I just wanted to challenge us all to continue to pursue our goal of health equity for everyone, pursuing social justice, not just in the hospital, but also out in the community. And my last little thing to help benefit myself, we have consistently hosted youth outreach and pipeline related initiatives in the STEM Center for at least the last 6 years, and work with local nonprofits as well as local high schools. These efforts have been largely funded by the donations of many of our attendings and from the Department of Emergency Medicine, but it would be great to have some institutional support. So I figured I would use my platform while I'm here. So thank you all for the honor.
Congratulations again.
Congratulations.
Thank you.
Well done.
So, Ms. Amos, is that, does that conclude the employee recognition?
Thank you, Debbie. I believe that does indeed conclude the recognition. I'll turn it back
Thank you
over
very
to
much.
you, Chair Taylor. Thank you.
Thank you very much. Again, we'd like to just say that the board really appreciates the work and this afternoon's recognition, and also just, I would like to say, quite frankly, thank you for all you do, quite frankly, both of you, to support our community, to support Chicago and Cook County broadly, and we really do appreciate it. Thank you. The next item is public testimony. Madam Secretary, do we have any written testimony that was submitted to be read into the record?
We did. We received testimony from representatives of NNOC, statement on behalf of all National Nurses Organizing Committee RNs. This Monday, for the second time, NNOC RNs delivered their message and demands to Cook County Board of Commissioners President Tony Preckwinkle, along with our demands to take action to retain the few RNs CCHHS has left at the bedside. We also provided an evidence-based accounting of how current hospital staffing with agency workers is harmful to our patients. Patients who have seen enough harm. She refuses to respond, refuses to listen, refuses to prioritize our patients as a true social safety net over hospital profits. It is broken logic, a true failure in deductive reasoning, to not see that the cause of this hospital system's nurse retention problems are not the nurses you have who remain loyal. It's the nurses you do not have and the working conditions that create for county RNs. A temporary nurse is not a county nurse. Our patients deserve better. County nursing talent is leaving for other hospital systems and agency employment because those employers understand retention in a pandemic requires incentive compensation. County is allowing the nursing shortage created by their long-term inadequate staffing practices to be aggressively amplified by ignoring what their nurses are telling them they need. In addition, reporting regarding how many permanent nurses still work at CCHHS has been difficult to obtain and incomplete. Someone wants to hide the ball. Registered nurses demand better than this. Cook County taxpayers deserve better than this. Cook County Health and Hospital System patients deserve better than this. We once more offer accurate reporting on the state of hospital staffing and the threat to patient outcomes before seeking new audiences who may listen and act. We would like to provide meaningful context to the situation county nurses are truly in. There's been talk of the nursing shortage for over a decade. The last year has been the worst the nursing profession has ever seen. The hospital has told us that this is due to record levels of nurses retiring, possibly due to COVID-19, and increased levels of violence toward healthcare workers, and not enough teachers to churn out new graduates. But according to the 2017 U.S. Department of Health and Human Services report on supply and demand of the nursing workforce from 2014 to 2030, there are enough nurses to meet the demand in most states, some with a surplus of which Illinois was included. In fact, Illinois is projected to have a 2.6% surplus of registered nurses in supply by 2030. So if there's in fact a surplus of nurses, Why is CCHHS pushing the rhetoric that there's a nursing shortage and not enough nurses willing to stay in direct care? It is a known hospital practice to understaff RNs on every shift in all units possible. Why? Because nursing service is included in the price of the hospital room. Unlike physicians who can bill separately for their services, if admitted to a general care bed, your nurse may have 5 patients or she could have 9 patients. But the room and board bill will be the same for each patient no matter how many patients the nurse has. Therefore, it is more profitable or budget friendly to have fewer nurses taking care of more patients. For this reason, county hospital practices bare bones staffing. When COVID-19 hit and there was a surge in admissions, many temporary nurse positions started appearing through temporary staffing agencies because we could not meet the staffing demands for the influx of COVID patients. These temporary RN positions pay 3 to 4 times what permanent county staff nurses make because demand has been so high. Temporary nurses are somewhat akin to a substitute teacher. They are used as a supplement when hospital staffing is not adequate. They receive little in-hospital training, approximately 4 to 8 hours, and are expected to jump in and take patients, and permanent staff are expected to help them acclimate. As you can imagine, county nurses have felt insulted the entire pandemic. Our hospital that we've been loyal to, many of us for decades, is now expecting us to mentor new batches of temporary nurses every 8 to 12 weeks. Many county nurses decided to leave their long-time positions for temporary positions. At John H. Stroger Jr. Hospital, we lost upward of 100 nurses that went to pursue these positions. And the number is still growing rapidly. As a quick fix for this mass exodus, Cook County started hiring temporary RNs. Many units are currently staffed with 50 to 75% temporary RNs. Some days the percentage is higher. Why does this matter to the board? Temporary nurses are also trained RNs, are they not? As long as nurse-to-patient ratios remain decent, patients should still receive proper care, correct? The answer is not that simple. County RNs are evidence-based researchers and medical professionals. We know that the evidence around temporary staffing of RNs is mixed. Some studies found increased patient falls and decreased quality of care, while others found no differences, which means there's probably another confounding factor. We believe it isn't that different. It isn't that temporary RNs are bad nurses, but the percentage of temporary workers per unit is far too high. Temporary RNs are less familiar with unit layout, policy, and procedures. This is not a hindrance if you have a decent number of permanent staff, say 75% or more, because then the temporary RNs have resources they can rely upon to point them in the right direction. When county nurses are scarce, temporary workers must do the best they can with no one to guide them. This can lead to increased patient complaints, decreased patient satisfaction, and more drug errors. A study by Senek et al. In 2020 found that an increase in the proportion of temporary staff significantly increased the amount of care left undone. The same study concluded that fully staffed shifts with a large number of temporary RN staff had the same amount of care left undone as a severely understaffed shift with no temporary workers. Care left undone has been associated with poor patient outcomes and increased mortality. Another study found high levels of temporary RN staff resulted in a substantial increase for hazard of death, while temporary staffing at low levels had no increase. Despite these facts, county solution to nurse staffing issues is to hire more temporary nursing staff and to refuse to offer retention benefits to current permanent nursing staff. Hence, more permanent nursing staff will be leaving. Across the country and across the street, hospital systems have offered their current staff retention benefits such as wage increases, bonuses for extra shifts, and lump sum retention bonuses, but county has done nothing. They remain silent. Why does this matter to taxpayers? The county system is the safety net hospital for all of Cook County, meaning we nurses take care of everyone regardless of their insurance status and their ability to pay. That means that the taxpayers support the hospital. A study conducted right here in Illinois by Laster et al., which included 87 acute care hospitals, found that if medical surgical units staffed with a 4-to-1 patient-to-nurse ratio during a 1-year study period, more than 1,595 deaths would have been avoided and hospitals would have collectively saved over $117 million. Spending more money on permanent nursing staff saves money in the long run. County investing in the permanent nursing staff it has left through retention benefits and increasing wages will make positions more desirable in hiring. This is directly more beneficial to the hospital, patients, and taxpayers than padding staffing with temporary RNs because it will improve patient outcomes, which has been shown to save money. Offering retention benefits and raising wages somewhat would be less expensive than hiring temporary workers at 3 to 4 times the rate of permanent nursing staff. Cook County's behavior towards its nurses indicates the complete devaluation of the permanent staff that have remained loyal and believe in the mission of quality care regardless of insurance status. It also indicates that the hospital board and system does not really care about improving patient outcomes. There is not a nursing shortage, just a shortage of nurses willing to work in hospitals that force nurses to risk their licenses by working in unsafe conditions for substandard pay. Registered nurse leaders of the National Nurses Organizing Committee have demanded that the Cook County Health and Hospital System Board of Directors provide some form of retention bonuses, pandemic-related differentials and bonuses, accurate reports of permanent nurse staff vacancies and hires, respect, and dignity. To put it simply, the response has been a flat no. Whatever the reasoning, Cook County needs a new set of priorities in light of all that has transpired throughout the COVID-19 pandemic. We believe it is time to go on the record about the true state of the nursing profession as county is leading in failure to retain, exacerbating the staffing circumstances born of their own budgetary prioritization. County nurses' loyalty to both profession of nursing and the county's patients demands so much more than silence. That is not how heroes are meant to be treated. And that concludes the testimony.
Thank you very much. We recognize that this is a difficult situation that requires
Sure. I just want to be able to say that we are very committed to making sure that we find a way to both be able to attract new and retain our current nurses. We are working with our team and will continue to work with both our nursing leadership and NNOC to address this. We have some proposals that we're looking at. As we know, nursing shortage is a national issue right now as we continue to look at how we move from the pandemic and high utilization of temporary nurses across the country back into permanent hiring and retaining. We have some ideas that we are exploring to see what we can do and remain committed. Most recently, we had nursing fairs. We have engaged in the community. We continue to have, and we believe, a robust employment program where we have been able to contract with our nurses union to create a strong set of benefits, including full tuition reimbursement and other types of programs and pension that differ us from most of our other peers in the healthcare space. And we're going to continue to see what we can do to make competitive packages. For patient safety, we monitor very closely our ability to make sure that we are rendering the safest patient care. The utilization of agency is necessary to be able to make sure while we are trying to fix our vacancies that we are able to meet safe patient care and that we're following the Illinois Nurse Practice Act that is required. And so we are making sure we monitor and we meet the availability for safety. We make sure that we meet the availability for safety to take care of our patients, but we remain committed to figuring out what we can do to be the employer of choice for nurses. And we will continue to work with our partners, with our nursing leadership to make that happen over the next few days and weeks ahead. And we will not stop until we make sure that we have accomplished that aim.
Thank you very much. We appreciate it. Thank you. Please keep us updated on the progress.
We will do. Thank you.
Next on the agenda are the board and committee reports. The minutes of the March 25th board meeting and the special board meeting convened on March 28th are being presented for review and approval. Approval will take place in the combined motion later in the meeting. Are there any corrections or revisions that need to be made to the minutes that were sent in advance? Hearing none. Next, Director Prendergast will review the HR Committee special meeting minutes.
Yeah, there's a button, right.
Morning, everyone.
Yes.
Excuse me, hold on, Director Prendergast. Can we ask everyone who's not speaking to actually mute yourselves until you're ready to speak? Thank you.
Okay, good morning. Yes, thank you, Chair Taylor. The Human Resources Committee held a special meeting on Thursday, April 21st at 11 a.m. The next regular meeting of the Human Resources Committee will be held on Thursday, May 19th at 12 noon. Note, we are not planning to have staff review reports from the meeting. If any additional questions are raised regarding the presentation or metrics contained within the minutes, staff will be present and ready to address. The received report, which is included within the minutes, included the report from our Chief Human Resources Officer, Ms. Valerie Amos, which included information on the following subjects: the FY22 metrics, the HR optimization recap, the HR transformation updates, the associated timeline, the recruitment fair, the recruitment event highlights, and job tracker examples. There was a request with regard to employee resignations. A request was made for information on reasons for leave obtained from employee interviews. As follow-up, Ms. Amos will share the results of the most recent.
Someone is unmuted. I can't hear. Someone is unmuted. Please mute. Whoever is calling in on a phone is unmuted. Please mute your phone.
Okay. Ms. Amos will share the results of the most recent Press Ganey Culture of Safety Pulse survey with the directors. There were no action items presented for this meeting. The committee did recess into a closed meeting, but because there were no action items associated with the closed session, the minutes can be approved when the board is ready for the combined motion later in the meeting. Please hold for the combined motion, and that concludes my report, and I'll turn it back over to you, Chair Taylor, unless there's any questions. Thank you.
Directors, if you can hold on one moment, we're resetting the room sound in the boardroom, so it'll just be a minute.
Because I couldn't see anyone that was, you know, reflecting. Ready? Okay.
All right, thank you, Director Prendergast. Next, Director Munar will review the Managed Care Committee metrics with Aaron Galena, Interim CEO of Health Plan Services. The committee did not meet this month, so those metrics are being presented directly to the board.
Thank you, Chair. I will turn over to Interim CEO for County Care Health Plan, Mr. Aaron Galena, to review our metrics.
Hello, Director Munar. Are you speaking? You're mute.
I was just introducing Mr. Galena for review of the metrics. Mr. Galena?
Okay, thank you. Aaron, are you ready?
Thank you, Director Munar. Yes, I'm ready. And I requested Control W, so hopefully I can go through this. All right, thanks. All right, we'll start with our usual plan metrics today, and then we'll start to go into a deeper dive on some county care enrollment trends, since this is the first quarter coming out of the period where we see most of open enrollment activity. So in terms of overall membership, we continue to see growth of 3,000 to 4,000 members a month. So we've increased to 431,000 members, and looking forward to May, we see membership right around 435,000 members. ACHN impaneled members continues to increase as well at 44,000, and is continuing to be right around 10% of our total impaneled members. In terms of market share data, we continue to see county care at the leader in the Cook County market at now 32.4%. This data is through January, so we see that market share number continuing to tick up over time. This shows enrollment trends versus the overall Cook County Medicaid market. So you can see the trend tracks pretty closely to what's happening in terms of overall enrollment, though we've outpaced the overall Cook County market with a 10% increase over the past 12 months versus the overall Cook County market increase of about 6%. In terms of our membership compared to budget, we're continuing to see growth, as I mentioned before, and starting to outpace our budget assumptions. So as we continue to have redetermination pause with the public health emergency, which has now been extended through July 15th, our budget assumed that redetermination would start earlier this year. So we're continuing to outpace that budget assumption and expect that will continue. In terms of operation metrics, all of our operation metrics shown here continue to perform within our expected SLAs. Inpatient acute admissions per 1,000. So the red bars are the prior period, the blue bars are the current period, and the light blue shading is our projection. So you can see that overall we've seen a pretty consistent trend this year of lower inpatient utilization per 1,000 than what we've experienced in the year prior. In terms of vaccination rates, we are at 55% now of members with at least one dose of vaccine, and we continue to see this grow a couple thousand members a week, basically, that we're seeing get vaccinated, and this percentage continues to climb a couple percentage points. In terms of claim payments, we continue to see good trends here. We had a little bit of an uptick towards the beginning of April, but have seen that come down in recent weeks and are right around that 30-day target. And that's really reflected on this slide. When you look at the aging, you can see claims over 30 days in the 30, 60, and 90-day aging categories continue to be a very small proportion of our overall age claims. Transitioning into membership trends, this slide, which we shared during the strategic planning meeting, just shows membership history for county care since the beginning back to July of 2014. A couple periods that we've had historically of very significant growth. You can see when we took on the FHP and ICP populations back in late 2014 and early 2015, and then the acquisition of FHN and Aetna membership, which occurred right at the end of 2017, beginning of 2018. And then over the past 12 to 18 months as the pandemic driven enrollment has hit. This slide shows our average enrollment span. One of the trends that we're continuing to see, especially as redetermination is paused, is the average length of time that a member is in our health plan continues to extend. So right now, the average length of enrollment is approximately 33 months, and about 60% of our county care membership has been enrolled within the plan for at least 2 years. And this is an important metric for us for a number of reasons, but in particular, we see cost and utilization really level off for members the longer that they're engaged with our plan. So the longer duration, we see much better utilization and cost containment patterns with members. This shows our historical market share data from 2018 through current, and we've added sort of the auto assignment impacts over time here as well. So this slide shows the bars are our county care membership, and then overlaid on the line graph is our percentage of market share. And you can see really over the past 12 to 18 months, as we show on the other slide, that this has started to climb. but generally has ranged between 30 and 32% historically. This slide shows overall market share for the entire state of Illinois. This isn't something we regularly show to the board, but I wanted to share this. County Care previously was fourth overall in terms of total market share in the state of Illinois, and we've now actually moved into third place over the past month. In terms of the Cook County market share trends, this shows a breakdown of the past year, really over the course of 2021, how market share has changed by each MCO. And you can see County Care has grown the most during this time period with an increase of about 1.2% from 31.2 to 32.4. Most of the other plans have remained pretty stable, with the exception of Meridian, where it looks like most of that market share that we've experienced has came from with Meridian dropping about 1.3% during the same time period. This slide shows our choice enrollment. So we've talked a lot historically about auto enrollment and the impact that has, but we're also spending a lot of time at the plan focused on driving higher choice enrollment into the plan. So you can see this shows how many members are choosing us. The left-hand side scale shows number of members, right-hand side is market share of members that are choosing us. And you can see, especially during the open enrollment period, we saw a pretty significant increase in December and January. This shows a enrollment comparison of new enrollees. So the red is what we call true new members, so members that have not historically been in the plan. The green bars are members that we may that we see potentially leave the plan and then they come back within a 90-day period, or a number of reasons that can happen. And then there's some what we call reinstatements that get eventually reinstated back to the original date that we saw them drop off of the plan. But I think the take-home point is that about 3 out of every 4 new enrollees that we're experiencing right now are brand new to the health plan.
Mr. Galina, could you maybe give us, you mentioned that there have been, you've taken some specific actions to drive choice. Can you maybe highlight some of those for us?
Sure. So regarding choice, we've really tried to evaluate that across all of our different touch points with members. So everything from how our member incentives are designed to some really focused groups around CAP scores. So that's a process. We get member surveys and see the feedback from member surveys that talk about issues from access to care, access to specialty, how they view our call center, for example. And so coming out of that data, we've tried to tailor interventions around each of those different points, as well as continuing our work with providers, so that we're viewed very positively by providers who really are one of the biggest drivers of how members view a health plan.
Thank you. We note the uptick in proactive choice, and so any of those efforts we want to support and continue.
This slide shows membership gain from auto assignment versus choice historically. So you can see the blue bar is auto assignment, where most of new members that are coming into our plan are coming from. But you'll also note in the dotted blue line, which shows attrition of members over time. So we see higher amounts of auto-assigned members that come into our plan, but also a higher amount of those members tend to leave the plan, where members that come in by choice have very low attrition. So we see a smaller number who come in via the choice process, but also when they choose us, they tend to stay with us. We've also targeted initiatives at this auto assignment population, specifically around retention. So really trying to ensure that we get engaged with that member within the first 90 days they come into the plan, that they get engaged with their PCP having a PCP visit within the first 90 days of being in the plan is really highly correlated to retention. And then, of course, we're trying to complete health risk screens and other activities from a care management perspective as members come into the plan to ensure that we stay, that we get connected with them. This shows member attrition. So there's two reasons that were provided on the state enrollment files. One is called term of benefits, and the other is called no reason given. Term of benefits generally correlates with effectively redetermination or a member losing Medicaid eligibility. So you can see this has been fairly minimal. There are some other reasons with the redetermination pause right now that a member may lose benefits. They could, for example, move out of state or move out of county in our case. And then the blue bar here shows no reason given, which is membership that may make an active choice to leave the plan. And when that happens, we tend to see members that are auto-assigned come in, and then they will make a choice to switch to another plan. And usually when that happens, Blue Cross is the highest plan in terms of volume that we see members. So here you can see that Mco Enrollment Change, and again, not surprisingly, during this open enrollment period when members have that option to switch plans, which they can only make that switch once a year, outside of the period where they initially come into the plan. In December, we saw the biggest increase. So right during the middle of the main open enrollment window. And again, 53% of those members who did switch chose to switch to Blue Cross. In terms of overall performance during this open enrollment period, we saw overall growth of about 0.8%, which we view as a pretty positive result. Historically, during this period, we've seen a net loss of members. On average, going back over the past 3 to 4 years, that net loss has been somewhere between 1 and 3% of our total population. So I wanted to talk some more about redetermination. And since this original slide was drafted, the PHE now has been extended through July 15th. So assuming that there are no further extensions, we would expect redetermination to potentially start by the state sometime around August or September, with the first impact to members likely in the September to October timeframe. Of course, the PHE could be extended again, but right now our planning efforts are underway, assuming that there won't be another extension. In terms of redetermination efforts that are happening right now, one of the biggest efforts is to ensure that we have updated demographic data. So HFS has a hotline where they are trying to get updated member information to ensure that the redetermination forms and information get out to the correct addresses for members with correct phone numbers and all of those things. And so right now we're pushing really hard to get the information out to our members to make sure that their information is updated with the state. So when the state begins that process, that the information is getting to the right place. And then, we're really pursuing a very multi-pronged strategy around redetermination. So everything from marketing and outreach to how we text message, and again, really trying to hit every touch point that we have with members, from our call center to how they interact with PCPs to how they interact with pharmacy script pickup, for example. Every touch point that occurs, we view as an opportunity to get information about redetermination in front of our members. And so that's really what we're systematically going through right now, and ensuring that we have a process in place that drives that information to the member across each of the touch points. So here are some more specific examples around that. So we have within CCH, an application assistance team who can help members actually fill out the redetermination forms. And they have an ability to go also directly into the state system to assist those members. So As a health plan, there's some restrictions on how much we're able to assist a member through this process. But we're able as a health plan to really do a connection over to the application assistance process at CCH, who can then really help the members through the process. We are looking at community events planning, electronic communication, so pushing out information via text, email, of course, outbound calling. We're working with our care management entities to ensure that members are flagged for all of our care managers, that they're up for redetermination and when that date is, so the care managers can provide that information. Similarly with our call center, to ensure that our call center reps have that information, and when a member calls in, they can talk about redetermination with the member. We're looking at point of sale pharmacy opportunities where when a member comes to pick up their script, they can also be flagged to the pharmacy so that the pharmacy can provide information to the member. And then we're also working with Chicago Public Schools, who has a very large proportion of our children are enrolled at Chicago Public Schools, where we can leverage that resource to get information out. Then, of course, provider engagement. We are pushing that same information and flagging to our PCPs and their empanelment data, so that when a member comes in for a PCP visit, that the PCP is aware that the member's up for redetermination and can provide information to them. And then, of course, marketing and social media outreach, and then really just across the board staff training to ensure that all of our staff are up to speed on the latest information around redetermination. So any interaction with the member, they know where to find information and provide that information to the member. So here's just a sort of work plan and timeline for some of these different efforts and when we're really scaling those up. So you can see a lot of this over the next several months is some of that background work to ensure that we've got the right flags and data flowing. And then as we get the more specific dates of when RED will begin and what members are going to be up for redetermination in a given month, most of these efforts kick off in earnest. And with that, I am going to hand it over to Karen to talk a little bit more about our marketing campaign and metrics.
Good morning. Thank you, Karen Stancic, Chief Communications and Marketing Officer for the health system and the health plan. Debbie, are you able to grab control back? Great. Thank you. I'm only going to go through a couple of these slides this morning. There's a significant amount of detail on the back of this deck, but I wanted to just come back now that the 2021-22 choice campaign is over, if you will, the bulk of it anyway. I wanted to just go through it with the board. If you looked at this matrix from last year, you would see that it was far heavier on the digital side than on the out-of-home side. The out-of-home pieces that are all those red boxes, the digital are all the orange. And that's simply because of the pandemic, right? Last year, everybody was still in their houses. And so we went real heavy on the digital side. This year, we were able to go back to our traditional strategy. And we know that when we do digital campaigns with an out-of-home component, that our campaigns are stronger and they perform better. So with that, Debbie, could you go to the next slide? Thank you. So the 175 million campaign impressions since the beginning of the campaign, so through March of 2022. Again, if you looked at the digital impressions and the out-of-home impressions from last year, your digital would be higher, your out-of-home would be significantly lower. So these are the impressions. So we had about a $1.3 million advertising buy this year, and everything performed well. I want to point out that 19,000 calls to the call center those are calls we can track. 13.6 thousand of those calls are conversions. A conversion is measured as a call that's longer than 40 seconds. So again, the campaign performed very, very well. I won't go on to the next slides unless folks are really interested. I just want to where we're at now is winding down this campaign. As you'll recall from previous years, we try to stay in market, at least digitally, through the entire year. We're working closely with Erin's team on a redetermination campaign. We've got some ads in market now, again, focused solely on making sure members' addresses are up to date. And we're already beginning our choice period for 22-23. And as you will recall, that always starts with a heavy research component. So with that, that's all I have unless folks have questions.
Actually, I do. Do we have a, Erin or Karen, do we have a specific goal? Like what would we call success in terms of retention after redetermination? That would correctly choose. What would we call success?
Sharon, I'm sorry, I'm having a hard time hearing you.
Do we have goals in terms of success as we think about the campaign? How will we know that, what would we call it? How would we call it successful?
Yeah, well, that's the old marketing challenge, right? One never really has the pure data. You know, I think when you look at the tables that Erin showed us, where we see that the choice numbers are going up at the exact time our campaigns are in market, the phone calls are going up at the exact time our campaigns are in market. Those are clear indicators that we're marketing to the right groups in the right demographics and in the right zip codes. And so we take a really hard look at, once we get the data file from Erin's team, we go back and do an analysis of where we got our new members against where we did the bulk of our advertising. All of those activities are currently underway.
And Mr. Galena, from the health plan perspective, what does success look like in terms of redetermination?
Yeah, thanks, Director Muir. So I think specific to redetermination, we've got pretty clear historical data on how well redetermination, how successful redetermination is in terms of members continuing their coverage. That historically for county care has been around 80%. We've been the highest performer in that. To give you some perspective, the average is around 60% in terms of successful re-enrollment. You know, I think one of the things that we're looking at very closely right now is trying to understand how those percentages may change in the post-pandemic period, right? Because we've seen a big increase in enrollment with members who you know, may now be shifting as the economies open back up. So you know, part of what we're going through right now is an exercise of trying to project out in the future what enrollment may look like, and really trying to do that at a detailed level where we're looking at the population that's enrolled with us since the pandemic versus what you know we might call our legacy population that's been with us sort of pre-pandemic and for a longer period of time. So so yeah, to give you some sense, the historical average has been around 80%. And then Chair Taylor, to go back to your earlier question around initiatives of choice that's driven more choice enrollment, I do want to call out the marketing campaign, which I forgot to mention, and it's probably one of the biggest impacts we've seen. This campaign really hit the market around October, and we really started to see that increase in choice in that November and December time period. And certainly as we look at the marketing campaign, you know, we've got sort of year-over-year data, and I think, you know, this is far and away been our most successful campaign. And I think Karen and I have continued to evolve in being able to think about trying to get more specificity on exactly where to target and how that overlaps with other initiatives in the plan in terms of where we may be trying to grow our network or do some other things that tie into the overall marketing aspects. So.
Director Story has a question. Director Story.
Thank you. Aaron, I have two questions. The first one is, did I hear you say that those who do not do a redetermination sign up in large numbers with Blue Cross?
Members who tend to make a switch during the choice period. So if they choose to switch a plan, we tend to see those choose Blue Cross at a higher rate than other plans. So in terms of, and a lot of that we think is just driven by brand recognition, and especially right now where there's been a surge of enrollment, likely from individuals who may have had commercial coverage previously prior to the pandemic and then moved onto Medicaid. That's, I think, not necessarily a surprising result because they may have other history with Blue Cross that might be driving some of that comfort level with them.
Okay, so you think it's a lot has to do with brand recognition in terms of Blue Cross?
Correct.
Director Story, this is Karen. Blue Cross Blue Shield owns this market. They are the gold standard here. And so, there's no surprise, to Aaron's point, many of these folks who came into our plan in the last 2 years since the pandemic came off of a commercial payer. And it's likely many of them came off of a Blue Cross plan. So it's what they know, it's what they're comfortable with. And we've heard that exact sentiment in research.
That's good to know. Then that obviously then that gives us the impetus to focus during that time period that they're with us in terms of what Aaron referenced, our PCP orientation with respect to that patient population, that we obviously have to double or triple our efforts, whatever that number is relative to retaining that patient population, if we know that they're coming off of other commercial, in particular Blue Cross plans. So I'll leave that for another day. But I do have another question real quick in terms of our county care insurance product. And maybe this is something, Aaron, David, that maybe we could discuss at a later date in a follow-up meeting. The added value, what's the added value proposition of county care with respect to the domestic spend? I mean, we have this insurance product for a reason, and maybe at a later date, we could have a report out relative to that proposition.
Yeah, Director Story, I think we're happy to do that, and also happy to talk about some of the specific work that's happened around that area.
Thank you, Eric.
It may also be relevant for Finance Committee.
And just Director Muir and Chair Taylor wanted to just to summarize what Karen and Aaron said about what success looks like. The market has grown during redetermination because there is a larger number of people in it. For us, success will look at that we either secure or improve the percentage of market share that we have. So whatever that market condenses to, if right now, let's just use round numbers, it has 2 million lives and we have X percentage of those 2 million lives. If that 2 million after redetermination is 1.5 million, we want to make sure that we either kept or improved the percentage of market share that we have. It's an ambitious goal, and that's going to be a combination of having choice members and others in these campaigns, be able to bring new people, as well as being successful in auto enrollment. So it's a summary of what Aaron and Karen talked about in detail, but just wanted to sort of summarize for the board. It's to maintain or improve our market share of whatever the end is after redetermination.
Thank you. Helpful.
This is Director Curry. I had a comment. Karen, are you able to hear me?
Yes.
Okay. You mentioned Blue Cross Blue Shield as the gold standard. I kind of think in my own terms that county care is in fact the gold standard for the populations in the communities that we're serving. I really do. So could you just explain a little more when you use that term? I hear it often.
Yeah.
Blue Cross as the blue standard, as the gold standard.
Yeah, fair question, Director Curry. So when so years ago, those board members that have been around for a while have heard me say this for the last 8 years. The challenge that we have up against the Blues is that when they market their brand, which is their parent brand. You will not see the Blue Cross Blue Shield out there heavily marketing their Medicaid plan. Our plan is our brand. So I agree with you. When it comes to the patient population that we serve, we have, I'll say it out loud, we've killed it. Like, we really do own the market, and our numbers show that. But when a member, whether they're a Medicaid member prior to switching to county care, or they're a commercially insured member, the overwhelming majority of folks in this market are either covered by or dream to be covered by Blue Cross, right? That's just the power of their decades of marketing. And so they don't have to, when they're out there marketing their brand as Blue Cross, they don't have to go through all of the approval processes that we do when we market the county care product, right? So the county care product is only a Medicaid product, but the Blue Cross brand has a portfolio of products under it. They don't tend to, outside of Medicare, they don't tend to advertise their products. They only advertise the parent brand. That gets them around, quite frankly, it gets them around all of the state approval processes. And so they have that much greater brand recognition because it's that much easier of a marketing tactic for them. Does that help?
Yes, thank you, sir. Yeah, I just, again, my own personal county care is the gold standard where we rest, and I always say that. Thank you.
Director Keding?
Yeah, this is much more of a comment than a question, but I want to pick up on Bob's comment, which I think is 100% right on. And I want to urge us to continue to think about some of the implications of that. And one of the most, in my mind, profound implications is that we need to continue to think of county care not just as an insurance driving mechanism, but as actually a mechanism by which we provide health care to the people in Cook County who are Medicaid recipients and otherwise at the lower end of the economic spectrum, because this requires different approaches that county care has focused on, and I hope will continue to focus on and extend. And I think it's very important. We have to remember that most of the people who get care under the umbrella of county care do not get it from Cook County providers. They get it from other providers, and that's fine, but we want to make sure we're using this as a mechanism to really focus on the health of people in county care for whom we are not just the insurance mechanism, but hopefully the advocate for and the creator of programs that really enhance their health.
Thank you, Mike. I mean, I think I do have a kind of a question for Ms. Danzig. I really appreciate the example of Blue Cross Blue Shield marketing the brand. Have we done that? Have we marketed the Cook County Health and Hospital System brand globally? Because I think we have multiple products, and service options, and might also, use that kind of strategy.
So if in reference to the health plan, right, there's all these regulations that we have to follow. And while the county care product is under the parent brand of Cook County Health, it's different than the Blue Cross relationship, right? Because it's county care plus Cook County Health versus all straight Blue Cross. So, and the we have approached the state a number of times about how to do this within the rules. It's an annual conversation we have. So the answer to the question about the integration of both the health plan and the health system in a single campaign, we've not been able to get to a point where we're within the guidelines. That said, have we advertised the Cook County Health brand outside of the health plan? And the answer is yes, with the limited, resources that we've had. You'll see the marketing budget going up, over time. And Israel and I talk about this all the time. We're not spending enough time marketing the health system's brand as a provider, but we certainly intend to do that in the next couple years.
Any other questions for Ms. Danzig or Mr. Galina? All right, well, thank you both for those interesting and important presentations. We do not need a motion. The metrics and presentation for informational purposes only, and our next meeting is on July 22nd at 10:30. That concludes the Managed Care Committee report.
Excuse me, I believe before we move on, Director Story had his.
Oh,
hand
I'm
up.
sorry, Mr. Director Story, I just saw that.
Yes, David, I just hope that with the questions that I asked will be followed up at a later date. I'm not satisfied with the explanation relative to the questions that I raised. So I hope that the questions that I raised relative to domestic spend and the value of this product relative to our overall system, that we'll have a separate discussion about it going forward.
Thank you, Director Story. Yeah, those are captured in minutes. And then it's also an important discussion for a finance committee that regularly also reports out on the different programs in our financial metrics. So I think both. So we can make sure that between managed care and finance that gets attention.
Thank you, sir. I appreciate it.
Thank you. I'm sorry. Any other questions? Sorry, I missed your hand, your virtual hand.
Thank you. I believe that is it. Next, Director Keding will review the Audit and Compliance Committee meeting minutes.
You have the minutes in your package. The meeting was held on April 20th, and the open meeting portion was largely a review of the charter of the committee, and that particularly with regard to internal audit, we reviewed that and concluded that the existing charter was adequate and appropriate, and readopted it, and that will be included as an action item when we get to the combined action item at the end of this meeting. The committee did go into closed session, but there were no action items at the closed session. Some of the information presented in the closed session will be available again in the closed session today. And that's it for the Audit and Compliance Committee. The next meeting of this committee will be Friday, June 17th, and it will be at 8:30 a.m. and will be particularly taken up with the review of the audit, which we expect to be of the financial audit of the health system, which we expect to be completed at that time. Any other questions, comments? Then that completes my report.
Thank you. I would encourage all directors, if they're possible, to attend the June 17th meeting. That will be an important meeting, even though it is the Audit Compliance Committee meeting, as that the review of the financial report audit will be important. If possible, I would encourage all directors to attend. Next, Director Guggenheim will now review the Quality and Patient Safety Committee meeting minutes.
Yes, thank you, Chair. Good morning, everyone. The Quality and Patient Safety Committee met on April the 21st at 10 a.m. And the next regular meeting will be held on Thursday, May the 19th, also at 10:30 a.m. The committee received reports from Leslie Frayne, the Associate Chief Quality Officer, on the HRO dashboard, and also a regulatory and accreditation update. We also received a detailed report from the readmissions work group, in which Dr. Umair Jabbar and Cassandra Wadlington from Inpatient Care Coordination detailed the progress that had been made on reducing the number of admissions, particularly with respect to coronary disease. And in action items, Dr. John O'Brien, the chair of the Department of Professional Education, provided an overview of the presentation on resident and fellow training and presented the proposed clinical training affiliation agreements for this coming year. These were approved in the general combined action. In addition, we received reports from the executive medical staff of Stroger Hospital and the Medical Executive Committee of Provident Hospital in writing, summaries of the hospital-wide quality improvement and patient safety committee, and they presented the hospital staff medical appointments, reappointments, and changes, which were approved. The committee also approved the minutes of the previous Quality and Patient Safety Committee meeting from March the 18th. We did not go into closed session, and I will roll the action forward for the combined motion to approve the medical staff appointments and the training affiliation agreements. That concludes my report. That's the questions. Yes, Dr. Ketting, Director Ketting, did you have? No. Yes, I return it to you, Chair.
Thank you. Next, Director Ryder will review the Finance Committee meeting minutes. Director Ryder.
Thank you, Thank you, Mr. Chairman. Finance Committee met on Thursday, April 21st at 9 a.m. The next meeting of the committee will be held on Thursday, May 19th at 9 a.m. The committee considered the following action items, which are included in the minutes. We conditionally approved 32 contracts, procurement items. 34 were included in the original packet. However, 15 and number 23 were withdrawn. Number 21 and number 22 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. The committee also received and filed Cook County Health Grant Award related items and transfer of funds. The committee received the following reports, which are also included in the minutes. Minority and Women-Owned Business Enterprises report. 2 emergency purchases were reported. And report of the February 2022 year-to-date financials. The action items, reports, and presentations from the committee meeting are included in the meeting minutes. I want to thank Chair Taylor for helping me split duty on chairing the meeting. And if there are no other questions on the information, the minutes are being presented for the board's consideration as part of the combined motion to be made later in the meeting. And that's all I have, unless there are any questions. Right. Back to you, Mr. Chairman.
Thank you very much. The next item is a quarterly report from CCDPH, which will be reviewed by Dr. Rachel Rubin and Dr. Karen Josh.
Hi, thank you very much. And this is our second. Yeah, can you hear me all, by the way?
Okay.
Thank you so much. I'm here over at the Core Center Clinic. So thank you very much. And this quarterly report, it's our second of this year, is entitled the Cook County Department of Public Health Contact Tracing Initiative Evaluation. I'm giving you an executive summary. So the purpose of this presentation is to highlight the purpose and impact of our health department's contact tracing initiative. So I'll briefly review the program activities of the initiative and share major evaluation findings and discuss lessons learned and recommendations. So I'd like to start by acknowledging the hard work of our CCDPH staff, the CCH staff, partners, including but not limited to Proviso Partners for Health and the University of Illinois and Chicago School of Public Health. Those two agencies were the ones that cooperated in doing, they were contracted to do us with our, to do our evaluation piece of this CTI, Contact Tracing Initiative. And the incredible contact tracers that have worked with us, most are signing off from our workforce as tracers. Many are staying on in other roles as of this coming Monday. And it's been a tremendous initiative. We are still maintaining a small core of about 50 staff to keep forward with the contact tracing for COVID-19, which is likely to persist for quite a while. Next slide, please. By the way, the slides I just showed you were posters and communications that our community partners put together over the last year and a half. So first of all, we know that public health takes a community and that no one intervention alone can stop COVID or many other communicable diseases or chronic diseases that we deal with. So to accomplish this vision and achieve our outcomes, there were 4 components to the CTI, the Contact Tracing Initiative, that all work together to form a large program. One is we expanded our contact tracing efforts with close to 300 new hires at the height of our workforce hiring. We granted funds to community-based organizations in high-risk, under-resourced communities to provide communication training and resources to community members to support isolation and quarantine, because that's part of the contact tracing work. And we also granted worker centers funds to support communication training and resources for workers to know their rights in the workplace and to support health and safety in the workplace with respect to COVID. And lastly, we staffed, the 4th element was staffing CCDPH and partners to provide technical assistance, training, and support to these entities to help them execute work. So we provided technical support to our community organizations. Next slide, please. So I'm not going to read everything. You can read the bullets, but a mixed method evaluation was conducted by UIC in partnership with our health department and the Proviso Partners for Health to document what happened with our contact tracing activities. So that included helping partners report outputs, to track performance and address opportunities for quality improvement, and to explore partner perceptions of what worked and why they worked. And there were 6 overall outcomes, and we'll share a few examples of those. Next slide, please. So what happened? So these are the metrics. I'm not going to go through all the numbers. You can see them, and you have the slide deck for your records, but to show these were the main outputs of what we did in terms of communications distributed and trainings provided and resources distributed. And when we talk about resources, it could be anything from personal protective equipment to putting people in contact to get food support, transportation, anything that's necessary for people to help maintain their isolation and quarantine when they are determined to be a case or a contact with COVID. Next slide, please. So this is sort of a busy graph, but it basically shows that despite challenges with hiring in the mid part of 2020, CCDPH worked with contact tracers to improve performance over time. So once fully staffed, the proportion of cases assigned and interviews increased significantly. In other words, we were able to track more and more people. Obviously, the more staff we got on board. So as you can see, we improved over time, and especially by the spring of 2021, April, May of 2021, with a little bit of ups and downs, we had pretty sustained positive responses to the cases, anywhere between 98 to 100%, with a little bit of a dip in June, which I'll explain why, in terms of being able to respond in one way or another, or make attempts to respond to our cases of COVID that were reported to us. Not everybody would pick up the phone, not everybody wanted to talk to us, but we were able to try to touch base with everybody. The Contact Tracing Grant Initiative, which was supported by the state of Illinois, It was originally designed to end at the end of June 2021. And the state was late in informing us when and if the program is going to be extended. And so as you can see that little dip where it says end of contract, our response rates dropped a bit because we lost a significant amount of our staff who didn't know whether they were going to have jobs after June. And we kept saying, we're sure that you will, but we don't have a guarantee yet. And so we had a bit of a dip, but we very quickly recovered with the people that we had on site, because by this time we had this incredibly well-trained workforce. And you can see where we did training in April, but we had ongoing trainings with our staff on a weekly basis and have hired 2 training specialists that are staying on with us to do training throughout our agency with other funding. So we'll go above and beyond contact tracing to actually have training specialists with us, which is terrific. And as you can see that our productivity and our level of success with getting a hold of cases and trying to interview them has been sustained through the fall and into the winter of the year. Next slide, please. Okay, so an important value of working with our community-based organizations was that they know their communities best. CBOs therefore adapted, Cook County Health and Cook County Department of Public Health communication materials to help community members receive messages in the ways that they could understand through a trusted community. So they took the My Shot campaign materials, they took other materials we provided, and then modified them to their own community. Next slide. All right. So what changed as a result of the contact tracing initiative? We increased our partnerships and networking. We have this incredible network now of partners. We funded 42 CBOs and 6 worker-centered formations to do this outreach work in the communities around contact tracing. And many of them were able to continue that work within the vaccination sphere through another set of funding, through another grant. But we had 42 core community-based organizations, so we've developed very strong relationships with that will carry us into the future. Next slides, please. Okay, so this is a graphical representation of what changed. So our approach to COVID was multi-pronged, as I mentioned, and efforts to increase awareness of the CTI initiative and that our public health staff would be following up on reported cases and identifying contacts were done through various approaches. So in the spring of 2021, we put up a campaign called Slow the Spread, Answer the Call. And you can see that in the aqua blue-green box there. Slow the Spread, Answer the Call campaign. And the data presented here shows that following the period of that campaign, there was an increase seen in the number of COVID close contacts identified in the initiative. So people were more willing to talk to us and tell us who their contacts were. And while a direct link between the campaign and this outcome cannot be made, this graph indicates that there may have been a positive relationship between community outreach efforts and ongoing efforts to follow up cases to identify close contacts, which is what we wanted. And as you see this dip there, that's also when we were seeing a dip in cases. So when you see that the black graph dips and has a low level at about July, that's also the lowest level of cases that we had to date at that point. So this graph also follows along the what we call our epi curve of the COVID case rates in our community. Next slide, please. Next, please.
Hello. Okay, can you hear me? This is Debbie.
Yes.
Someone who is in the meeting is muting the boardroom. So please do not mute anybody else other than yourself. Thank you.
All right, perfect. So what can be sustained and expanded? Obviously, these partnerships that we built through the CTI not only help to expand their reach and facilitate their learning for COVID-19, but a foundational network was created with the health department. We have had community partners as part of our core work in the communities for decades, but this has been incredibly expanded. And we did this contact tracing regional learning and action network, which was this amazing set of workshops. And you can even read the quote from one of the community-based organizations who participated. This was a forum where there was learning and bi-directional exchange, and to develop a really strong foundation of a community network that will hopefully, and we anticipate will continue to persist for other types of work as the years go by. So next slide, please. Okay, so further, what can be sustained? These are just some other quotes. This is where the first one, if we decide to just do away with this network that's been created and everybody goes back to their own silos, then it's a failure. So we want to keep this going. Everybody is really enthusiastic and our community partners are terrific, and we hope to maintain this going forward. So these are just some quotes from various folks and community organizations that have worked with us. Next slide. Okay, so what were a couple of the challenges? Certainly a couple of things to highlight where it says lack of infrastructure to support the work, delayed activities. And that had anything to do with not being able to onboard people quickly enough, but also limited access to the state contact tracing data systems. We were given the dashboards to work with, and something that was on a Salesforce platform, which was the surveillance system set up for contact tracing for COVID, but we didn't have access to the back end so that we could download the data and look at our own trends and our own successes in our own communities, but only at a very low level. Luckily, we have these incredible epidemiologists in my department, especially in communicable diseases, who were able to sort of, it's sort of like when you break open your phone, they sort of did that. It was legal, but they went through and they were able to grab that data, and eventually we were able to build out our own data systems to support appropriate communications and also help with maintaining the quality and work within the contact tracing initiative. But it was a challenge at first. It took a while to do that. It took a lot of work and initiative to get those data systems working for us. Also, there were project silos, which may have prevented quality improvement and integration, but those things were recognized when we attempted to work with that. And also, at times, there's been a reluctance to tailor messages due to all the misinformation out there. That became quite intense and very hard to combat. Next slide. So what worked? So we provided all of this tremendous training for our contact tracing and adding supports. It was a whole series of trainings. Like I said, we have these 2 training specialists. So we were able to integrate more and more into what the contact tracers were capable of doing, including giving them mental health training so that when they're talking to people who are going to be very much under stress, when they've been told they're diagnosed with COVID, or somebody's being told that they're in contact with a COVID case and they may have an underlying condition that makes them very concerned about complications if they get COVID. So to know how to communicate well with people and to understand the mental stress that people may be under. We also provided this kind of staff and partner technical support to our community partners, as you can see from the quotes there, that our contact tracing workforce, those that were involved in the CBO part of that, provided a tremendous amount of technical support on this level to our partners. Next slide, please. And so the key takeaways, this is our last slide, which is basically saying that the key takeaways is that our contact tracing initiative design, including contact tracing, community engagement, and partner staffing, together likely led to COVID-19 prevention and or mitigation in our communities, is that we would have been much worse off than what we saw if we didn't have this initiative in place with this multi-pronged approach. Our CBOs and worker centers who have close ties to their communities are essential for bridging gaps in what the health department service delivery can do. And it's been effective by meeting people where they are, understanding people's fears and concerns. That's how we're going to make change, and that's how we're going to build trust. We've put together a programmatic infrastructure like the technical assistance providers, staff to support communities, engagement in spaces for discussion and learning like the Regional Learning and Action Network were really pivotal to this program. And evidence suggests that the partnerships and networks built through the Contact Tracing Initiative has laid the groundwork for other public health initiatives going forward. And we continue to invest in training and quality improvement activities. And finally, we provide staff capacity. We have provided staff capacity to conduct the work, including contact tracing and specifically to support grant and technical assistance to partners and training to expand our capacities for our CBOs. And finally, our contact tracers, those that have left our program, hopefully have gained an enormous amount of skills through the various trainings, as well as the actual work that they did so that they can continue to be strong public health advocates and partners and moving into similar jobs in the community. And I think the next slide is a thank you. So thank you very much for your time. And those are just what voice, yeah.
Thank you very much, directors. Do we have any questions on the very thorough presentation? Thank you very much, Dr. Rubin. There are no contracts being presented directly for the board's consideration. So if there are no other questions before the board acts on the minutes and action items contained within the minutes, we can move to the combined motion. I'd like to entertain the following combined motion to approve the following. Item 4A, March 25th board meeting minutes. Item 4B, March 28th special board meeting minutes. Item 4C, April 21st Human Resources Committee meeting minutes. Human Resources Committee special meeting minutes. Item 4E, April 20th Audit and Compliance Committee meeting minutes, which include the proposed internal audit charter. Item 4F, April 21st meeting of the Quality and Patient Safety Committee meeting, which includes the Stroger and Provident Hospital medical staff appointments, reappointments, changes, and proposed clinical training affiliation agreements. And item 4G, April 21st meeting of the Finance Committee meeting, which include the contracts and procurement items, grant award related items, and transfer of funds.
So move.
Second.
Second.
The motion has been moved and seconded. Madam Secretary, please take the roll call on the combined motion.
Roll call on the combined motion. Aye or nay, Director Curry?
Aye.
Vice Chair Deere?
Deere is aye.
Director Garza?
Aye.
Director Guggenheim?
Aye.
Director Harrington? Is absent. Director Kim? Is absent. Director Keding?
Aye.
Director Munar?
Aye.
Director Prendergast?
Aye.
Director Ryder?
Aye.
Director Story?
Aye.
And Board Chair Taylor?
Aye.
You have 10 yeas and 2 absent.
The ayes have it. The combined motion carries. Next is my committee report. Again, I would like to extend my personal thoughts and on behalf of the board to the colleagues and family of mental health specialist Jennifer Hamilton. I want to let them know that we here keep them all in our prayers and thoughts, and we'll continue to support them any way we can. I would also like to thank the board, the staff, and the community for their input thus far on the strategic planning process. We know that it continues and it's a work in progress, but we'd also like to thank everyone for the input that they've provided during the ongoing various meetings. I think we have an update today. I would also like to remind just all present in the public that after each of our meetings, our minutes are available to the public. For example, today, after we conclude, now that the combined motion is carried, our March 25th board meeting minutes and the 28th special board meeting committee meeting minutes will be available on the website for review, just as a reminder. So thank you. The next item is a report from the CEO. Georgia.
Thank you. So today we have two items. I'll first give my general report. Of course, the full report is submitted for the board, and then we will also then be going into our presentation of the draft strategic plan according to our timeline. So first we'll start with a summary, and then we'll go into a few highlights of the divisional reports. Just want to share with the board, yesterday was a very special day for our organization across Cook County Health, and it really was a special day that was made possible because of the partnerships that we have with our Cook County government, the Cook County Health team at our acute and ambulatory care sites, and then the Cook County Department of Public Health. All of those teams working together celebrated being able to give our 1 millionth dose of vaccine to a patient yesterday. We were truly excited to be able to reach that milestone. Cook County Health is one of the first health systems in the United States to have been able to have given over 1 million doses to help mitigate the most dangerous effects of the COVID-19 pandemic. And just want to start by saying how much I truly want to be able to recognize our staff, our team, and everyone who made that historic milestone possible. It really was the labor of so many who made that possible, working through the pandemic, working on nights, evenings, and weekends, and especially want to celebrate the partnership that made that possible with the state of Illinois, the governor's team, as well as the IDPH team and the members of the Illinois National Guard, who helped us to stand up so many of our large mass vaccination centers. In total, we operated 6 mass sites, but then we had almost over 1,000 pop-up sites and hyper-local sites that were also given to the community. So it was truly a special day, and thank you to the board for supporting us, and thanks to our Cook County Health team for making that possible. Also, in our highlighted in my board report is a discussion that on April 26th, joined by the Cook County Board President Tony Perkwinkle, County Commissioners Deere and Bill Lowry, the Cook County Health Foundation Chairman Joe Flanagan, the Cook County Health team, along with the Cook County team, were able to announce that we are officially launched in the open window of a $1 million Providence Scholarship Fund that will support students who are from and committed to caring for underserved communities. The Providence Scholarship Fund will be administering 60 scholarships this summer, including 30 to health professionals, including mental and dental students, 20 to high school students entering a healthcare program, and 10 to students in the allied health and undergraduate programs. Medical and dental students under the health professional programs will receive $20,000. The allied health and undergraduate high school students will receive $10,000. More information is available on our website, and we will put that website on our board website as well so people can get information. Truly, this is a momentous moment for us to be able to offer this type of education and building in our community. And we're truly happy and thankful to our county board, as well as to our team who made it possible, and the Cook County Health Foundation for making that possible. Also want to discuss it and just highlight for the board that on April 20th, the Cook County Health team hosted several visits and a roundtable discussion with the U.S. Centers of Medicare and Medicaid on achieving more health equity in our community and through the nation. More than a dozen officials attended either the visits or the roundtable, including CMS Administrator, the head of Medicaid for Illinois, and Illinois Governor J.B. Pritzker, and our team, as well as other leaders throughout the community in the Chicago-Cook County area. The visit also included a tour to the Stroger Emergency Departments, as well as a presentation from the Westside Collaborative, Cook County Health, that Cook County Health is deeply involved with. We're thankful to continue to advocate for equity and for the inclusion of care for all the residents throughout Cook County. Just moving to the divisional reports, and keeping in mind that we also have a presentation on our strategic planning. I'm going to just highlight some of the areas for everybody quickly to move forward and remind everyone to please make sure to read the highlights, as they're great reflections of the work that we're doing. Under our COVID-19 program incentive, we hosted a second $100 gift card giveaway for all community centers and for anyone who was wanting to make an appointment to receive their first, second, and third doses or boosters. Through this incentive, we distributed a total of 1,700 gift cards. We continue with our appointment scheduling to increase access and improve no-show rates. Our patient support center has started making reminder call to all patients scheduled for MRIs to increase show rates and remove patients that were already seen to free up capacity for others waiting on the list. This has shown a dramatic improvement in the ability to schedule new appointments and to make sure that patients were rescheduled if necessary. For our Women and Children service line, we completed a virtual video tour of the Stroger Hospital to market our hospital delivery service, and children's services for CCH. Our focus groups have given us great reviews on the ability to share information for upcoming mothers. In primary care, we continue to work on increasing access. Due to COVID and other challenges at the start of the year, we are slightly behind budget, but are pleased to prove that in March 2022, we were above budget by over 1,208 visits, totaling for 70,714 primary care visits in FY 2022. Also wanted to highlight on the next page, our Women and Children's Clinic, our HEDIS compliance is still monitoring to make sure that all children get their vaccinations, and we are over 80% compliant with children 2 years and over. An announcement for our Pediatric Specialty, our rheumatology clinic has begun every Monday morning. For our patient support services, our patient support center answered over 48,900 calls with an average speed of under 60 seconds. And then, of course, we are very proud to continue to make availability for under our infectious diseases program. Our infectious diseases HIV care, we collaborated with community-based organizations for locations in socioeconomic hardship areas and areas near Cook County Health ambulatory sites. We held community events in collaboration with Chicago State University, the National Kidney Foundation, Olive Harvey, Wright College, Above and Beyond Recovery Center. We distributed more than 85 home HIV test kits. We will expand our pediatric adolescent HIV and PrEP services at Blue Island Center through a collaboration with Stroger Division of Adolescent Medicine. And we also fully support the existing PrEP services at our Inglewood Health Center with our health educators and our PrEP coordination team and resources to promote program retention. On the next slide, a quick update from our CERMAC Center. From February 2021 to February 2022, 15,376 COVID vaccinations have been dispensed. Patients were offered Pfizer, Moderna, and Janssen. Booster vaccinations are being administered to patient population as well. Our current vaccination rates of active patients housed in the jail are at 63% have received at least one dose and 56% have received at least 2 doses. Preparation for the NCCHC accreditation expected in 2022 is underway, as well as continued preparation for accreditation of the JTDC survey on April 2022. IDOC has begun accepting transfers, and currently 351 detainees remain in our custody of IDOC. On our public health department, you heard a great update from our department and strategic planning. Just wanted to share, of course, that our staff across the executed plans for being able to have federal dollars and able to see CDH of close to 11 million in grants to enable our Building Communities initiative. The Behavioral Health Unit is working closely with the Justice Advisory Council to conduct a landscape study and analysis of crisis intervention initiatives and crisis intervention programs to be able to ensure that all the needs of Cook County are fully met. And then the Displaced Tuberculosis Clinic continues to prepare for a move to the Arlington Heights and Ambulatory Care Network. Under our health plan services, you heard a great update from our CEO today, and just wanted to be able to share that in March, County Care kicked off an initiative to prepare for the resumption of Medicaid redetermination at the end of the public health emergency. To the end of the public health emergency, approximately 25,000 members will be up for redetermination every month, and we will be working with them to ensure that they have the information they need to go through the redetermination process. Under our Providence Hospital, just wanted to highlight that our mobile MRI scanner and installation and staff training was completed. The first patient scan was performed on March 1st, 2022. In addition, the staff completed the training and the first fluoroscopy was performed on March 1st, 2022. For Stroger Hospital, just wanted to have a few quick updates. We successfully implemented the software upgrade and dispatching system for patient transporters, resulting already in reduced response times of transporters to help patient mobility throughout our hospital. We are redesigning our admitting center to improve access and reduce holding times for patients in the emergency department. And we are reevaluating our surgical block and anesthesia recovery models. We have nearly a 3-month lead time for outpatient MRI scheduling, and making the third MICs available appointments is our key priority, and we continue to improve access and availability. We also are continuing to have our regulatory readiness boot camps for leaders that will start later on this month in April. And we are planning for our stroke survey in May and coordinating with external agencies for a training exercise in June for a mock mass casualty event so that we are always prepared at the Level 1 Trauma Center. Those are the presentations for the divisional report. Of course, there are a few other highlights we encourage the team to please review. And now I am happy to move forward for our next agenda item, and to direct everyone to please look at the FY 2023 to 2025 strategic planning document. On the first page, just a reminder for everyone, that is the timeline. So in February, March, we held stakeholder feedback. On March 28th, we held our first Cook County Health Board of Directors review and aggregation of the feedback from stakeholders. And today, we are presenting the draft strategic plan that was submitted to the board and we'll review. Then we will be back in May for the official vote of the plan. I will go over the first few slides and then we'll turn it over to our Chief Strategic Officer, Andrea Gibson. Our first is our Cook County Health Mission, Vision, Values. As we talked about, a lot of our organizations to ensure that the mission is something that is recitable, known, and welcome throughout the organization. Our current mission says to deliver the integrated health services with dignity and respect, regardless of the ability to pay, to foster partnerships with other health providers and communities, to enhance health of the public, advocate for policies, and to promote the physical, mental, and social well-being of the people of Cook County. We are proposing the change that you have there, which is to establish universal access to the world's best care and health services for all Cook County residents, regardless of their ability to pay, so all may live their healthiest life. We believe this is really in line of what we're helping to build for the future. We have seen that we have done an amazing job over our 200 years. When we started, there was simply just not any type of service or delivery being done for all patients. And it's something that Cook County Health took very special and is part of their mission. Part of that is that we will continue that, but in the future, we also have to be able to address the challenges of access. And our most recent panel with CMS, access was highly discussed. As we start to see things, we're making sure that we have enough providers and we see an aging of our population. Even as we start to have expansion of Medicaid programs, which we're making great strides in here in Illinois, most recently being able to expand a Medicaid lookalike for individuals who are undocumented up to 42, the expansion of the Affordable Care Act, and so many other elements have brought people into service and insurance, but that doesn't mean that they have an impaneled provider able to see them or timely service that meets their schedules and demands. The future of healthcare will lie very central on access. And so part of that is our recognition to ensure that everyone must have access and that insurance coverage is part of the battle to the enablement of health, but it is also requiring that you have access and a provider to meet that aim. So part of this reflection and mission is to reflect our goal to ensure that everyone has access to the world's best medicine and health services, keeping true to our honor to make sure that that is available regardless of ability to pay, and reminding us of the aim that we want everyone to live their healthiest life. I'll stop there to see if there's any questions. All right.
Looks like you took input from the last meeting.
We did take input from the last meeting, very much so, as the board wanted to make sure that in our prep session, I just wanted to highlight, we did reinsert back regardless of the ability to pay. That is always a given, and we thought that was kind of true, but we wanted to make sure it's reminded. And the board also wanted to have the inspiring part of our mission, which is so that all may live their healthiest life. And that then tracks us to the next one, which is what is our vision when we are aiming for and what we want to make sure happens. And that is to ensure that we want to ensure healthcare is a human right. Our previous vision was in support of the public health mission. Cook County Health will be recognized locally, regionally, and nationally by patients, employees as progressively evolving model for accessible, integrated, patient-centered, fiscally responsible healthcare focused on high quality and improving the health of Cook County residents. I would actually say, to the credit of the team and the board, I think a lot of that vision has been realized today. And as we continue to look at the challenges that we're facing as a community, as a county, as a country, we really are wanting to ensure that healthcare is a human right for everyone. Director Cuddy.
Yeah, do you want comments now or do you want to wait?
We can take them now on these two, and then we'll switch over to the pillars.
Okay. I just wonder when we say to ensure healthcare as a human right, do we want to say health as a human right?
I like them both. let us think on that. I like that.
But we can't, we have much more control over providing healthcare than providing health. But the goal of healthcare is to get to health. So
make sure everyone's healthy. Absolutely. That's a very good point. Other comments on our vision? And again, this we reflected on the needs that were given from the board, all of our previous meetings, and Andrew also reviewed the input that we have. We also, the board had asked and made comments, and we went out and looked and worked with our team. The board had asked us to make sure that we also had a set of values for our care team. And so new to this proposal will be a set of values that we call iCare. And the values, of course, are what our team should use to make sure that when they're making decisions for our patient, there is a rubric that is provided. And so the iCare rubric stands for innovation, compassion, accountability, respect, excellence, and education. So when we are greeting our new team members, when we deliver care, and always at the back of our mind when we're delivering care and service, we're going to ask our patients to, of course, have innovation, compassion, to be accountable for their actions, to respect their peers, their patients, and everyone in our system, and to aim for excellence and to aim to continually educate ourselves, those that we serve, our patients, and of course, to be a strong component of education of future generations of healthcare through our teaching programs. And so the values will be central to what we are as an organization. And that was a request and a reflection of the board wanting to ensure that we had a set of values for our team. Any thoughts? All right. With that being said, we are still open to take more feedback as we finalize to a draft. Did someone have a comment? All right, then I am going to now turn it over to Andrea Gibson, who will walk through our proposed pillars.
Sure. Good morning, everyone. This is Andrea Gibson, Chief Strategy Officer. Again, we received feedback from various stakeholders and then more recently from the board, and settled on these as kind of the organizational framework for the strategic plan. You have received a draft of the strategic plan, and we will be, you can be in touch with us on any comments or suggestions that you may have through about May 13th, so that we have time to finalize the plan. We'll have to deal with reconciling anything that may conflict, but I'm sure we can work through that. So looking at these pillars, I'm going to take you one by one. So you have a general orientation to the strategic plan. I'm not going to read every item in it, but we can go to the next slide.
Just one question of clarity. Are these in a rank order, or are these just
Well, I always want, the pillar or the area related to patients and quality to be first. But it doesn't necessarily follow a ranking after that. But I'd be open to a ranking if that is a preference.
Well, I don't know that this is rankings. I think in our last discussion, a number of the directors highlighted the importance of health equity, community health, and integration. There seemed to be a lot of discussion about that. I'm not sure we say it's a rank order, but I just want to clarify that, make sure that we address that and the importance of that along with patient safety, clinical excellence, and quality. All right.
We can certainly move that up to be more front and center. All right, and Deb Santana has given me control, so you can see that little picture of me floating around. Deb, I don't know that I can advance slides. I'm trying. Oh, over here. Okay. So this gives you a sense of how we have the strategic plan structured. We're going to include more information about the organization in the strategic plan, but the meat of the strategic plan are these pillars. So under patient safety, clinical excellence, and quality, we define that as ensuring the highest quality service and best clinical outcomes by providing patients the right care at the right time in the right place. And the first objective is to provide safe and consistent care, consistent high quality care. So that's an objective. We have 3 objectives under this pillar, and then on the right we list results and how we might measure progress towards that larger goal. So this one includes meeting or exceeding benchmarks, having the patients have information that they need to make decisions about their health care, securing centers of excellence designations, continuing to build on our care coordination, and also providing a full spectrum of comprehensive care services for people. Looking at the right place, this is related to ensuring access to care for all patients in need in the right setting. So this focuses on the results of investing in key services, continuing on the magnet journey, having our educational training programs nationally recognized, increasing the number of primary care visits for our managed care and paneled populations, creating pathways for our justice-involved populations, and folding in a care access hotline. If you look at the last portion of this pillar, it focuses on the right time, and that is providing timely access to the appropriate clinical intervention. So you'll see access come up a lot. I'm sorry, is there a question? I just got a little feedback maybe.
Yes, Andrea, Mary
yes.
Goodtime, I do have a question. When we say, sorry, it's 2 slides earlier, it's when we say designate centers of excellence, is that a term of art, or is that something that we are going to decide? I mean, we're just going to say we are a center of excellence, or is there some external imprimatur in some sense?
Generally, a center of excellence is kind of in the eye of the beholder. So we have some latitude to set up standards, or what we think. There are some exceptions to that for some areas, but I think a center of excellence has some flexibility in it. So we would identify what those would be and tie those to metrics, quality metrics.
Okay, so I mean, we're talking about things like the stroke program, are we?
Right.
Yeah, okay.
Correct, Director. Well, the overall Center of Excellence, we would call the service line is hard to quantify. We would really only do that if there truly have been objective measures met, such as either achieving a certification. The Joint Commission now has a very robust ability to designate specific centers. Most recently went through primary stroke, moving up to comprehensive stroke, and then being recognized as a comprehensive stroke, or, you know, going after the American College of Surgeons Level 1 trauma certification for our trauma center, or pursuing those types of certifications. Sometimes even insurers have certain certifications that they would be able to achieve. So while the overall service line would be something that we're able to do, when we say pursue, the element says through best practices of care, we would actually pool and quantify what are those best practices, how do we service them, and do the training.
Thank you.
Great. So on providing on the right time, you'll see access come up a lot under different pillars, but there is a focus here on timely and reliable access, so people can see specialists and get the right care when they need it. Also ensuring employees are working at the top of their license to improve our wait times, and mitigating variation in life expectancy by focusing on access and specific disease conditions. And finally, under this one, working on focused outreach campaigns. So then the second pillar we've identified is patient experience, which is intended to develop systems of care and education that provide for an empowered patient experience. And we have three objectives under this pillar. One is to partner with patients, families, caregivers to optimize patient outcomes for the patient experience. And we would see this as a result in looking at the patient satisfaction scores improvement, looking at improving patient education and engagement, also focusing on patient navigation assistance, community outreach events. Oh, whoops, I'm skipping to the next one. So the next objective that we have on here is ensuring the organization always listens to the voice of the patients and that we're fulfilling their key needs and requirements. And so this, the results related to that would include community outreach events, increased response rates on Press Ganey surveys, and fortifying our existing patient family advisory councils. Lastly, the last objective that we have under patient experience is to empower patients to be involved in the decision-making and being proactive about their care. And you'll see there's a few technology related items here, including broader adoption of the patient portal, utilization of self-scheduling for patients, which I think would be a great empowering thing for us to do. And also, we would expect a decrease in emergency room visits, and we would focus also on just basic health literacy trainings. So the next pillar we have listed here is talent and teams, and this intends to serve, the description of this is serve as the employer of choice by supporting and investing in our workforce, recruiting the best talent and fostering robust teamwork. So firstly, supporting and investing in our workforce would focus on the training programs, professional development, career pathways, succession planning, decreasing the turnover of staff and reducing the overall number of vacancies, increasing employee engagement, and then continuing to build strong relationships with our union partners to lead to more employee retention and satisfaction. Recruiting the best talent, so really doing a number of things in this space, including improving our use of technology and recruitment resources, and having the hiring process be more timely and competitive in our local environment. Also, look at some options for flexibility and innovation in how we, plan to use positions. If there's more part-time positions, for example, that we could use more flexibility in that would emulate some of the changes in workforce nationally. Also, to focus and improve our focus on pipeline programs that would build early interest in working for Cook County Health. Fostering robust teamwork. Some of the key results there include extensive wellness programs, having employee-led projects that are supported, and having project teams represent all levels of care and services, not just a top-down approach. Having performance improvement programs that are based on just culture methods, and continuing to build on our employee recognition programs. For fiscal resilience, there are three objectives that we identified through this process. One, maintain financial strength, which would include developing a 3-year sustainable financial plan that's aligned with this strategic plan, maintaining a positive operating margin, increasing the county care reserve to mirror industry standards, and continuing to increase county care member utilization of Cook County Health Services. Secondly, optimize funding sources. So continuing to implement the revenue cycle turnaround plan and maximizing our third-party reimbursements, continuing to secure external funding, and also leveraging the Cook County tax allocation to support correctional and public health. Control costs and maximize efficiencies is the last piece of the fiscal resilience pillar. And that we think the results related to this will be that our annual targets are based on industry benchmarks for overall staffing, overtime, agency, and that this all will align with volumes and clinical complexity. Also, continuing the work that we've started about over a year ago on reviewing contracts and renegotiations so we can align expenses to take advantage of improvements in the market. And finally, leveraging the value analysis process to reduce costs. So, and health equity, which I think, I made a note.
Hold on, Andrea. Directors, I just want to make sure anyone had any questions. I didn't see any hands raised, but if anyone had any questions about the two prior points, our workforce and our fiscal resilience are very important, so I want to make sure everyone observed those if they didn't have any questions.
Looks like Director Guggenheim has a question.
Director Guggenheim?
Sorry. Yes, thank you. I'm struggling to reconcile lofty goals in patient care and patient experience. And of course, I applaud and second the lofty goals. But when I compare that with what I hear sort of not only month after month, but actually year after year, about the shortage of staff, for example, in the radiology department, where the turnaround times remain dismal because there simply aren't enough technicians and radiologists to do the work. and also the perpetual shortage in the nurse staffing areas. I mean, it just seems sort of problematic to me. I mean, how are we going to sort of ever get to this stage if we can't fill the jobs?
Sure. I think I can take a pass at that. I think these goals, while they sound lofty, will have very tangible things behind them. And so to give just some quick examples of what we mean by that is that part of what we have a problem with is retention, and we want to make sure that we're training our employees so that they feel that there's upward mobility in their career so that they don't feel they have to leave. And so creating a Cook County University and training program with a learning management system that would allow them to do that is something we don't have that our competitors do have. And so when we're looking at how we can invest and train so people feel that we're making sure that they feel that they're getting a return on their investment to us, those are the programs that would exist. We don't have that now. When we talk about technology and improvement of ability to source best candidates, some of our technology right now is part of the problem on speed of turnaround in the recruitment process. And so we get candidates in and we're seeing those numbers come in, but sometimes our systems are difficult and they could be improved. I don't think we'll ever change them completely, but they could be improved to make sure that we're more timely. So one of the things in a very competitive work market is that labor market is you want to make sure that if there's someone that says, I'm ready to come work for you, that we give them an answer, we get them in, we get them through our processes, we can remain compliant to all of our employee plan, but we're able to move quickly and efficiently through those steps. There are some improvements that we can do to that. When we look at some of the things that you look at, and part of the reason is I really like this question because I think it really calls us to task to make sure we're doing what we need to, is that when we're offering candidates timely and competitive offers, we have to consistently be evaluating not just when that one employee is there, but we have to be looking at what we're going to pay across the market, are our positions at the right area, so that when it comes time to negotiating our contracts and what we do, we know that we're in the right areas for that advancement. And then how we build residency scholarships, pipeline programs. You saw a sample of that today, where we're going to start building doctors very early. Hopefully, those doctors, when they go to medical school and law school in 4 years or 8 years, and they finish, they will remember the Provident Hospital Scholarship Fund and decide to come back to Cook County Health, who helped them do that work and get their degree and visit with us. And we want to expand that through nurses and then even to specialized programs in allied health like phlebotomy and others. So these, while they do sound lofty, are very strategic, specifically enumerated. And then as we move past the strategic plan implementation, we will give you work plans for each one that will have very precise and particular measures on how these goals will be accomplished.
Okay, thanks.
Thank you. Andrea?
All right, any other questions before I move on to health equity? I don't think I see any. So for health equity, and I think Chair Taylor will move this up in the sequencing to show that it's how high of a priority it is. But this, we have two objectives. One is listed here as create just spaces. And so again, this is looking at the some of our physical infrastructure, like the physical locations of our healthcare locations help resolve gaps in access to care. Also, that our patients feel comfortable and at home when they're receiving care with us, and that our workforce reflects the diversity of our patients. Also, the patients that are receiving healthcare information in the language of their choice, we're seen as a leader in LGBTQ healthcare, that we advance MBEWBE participation in our procurement opportunities, and continually look at our pay parity to close race, ethnic, and gender gaps. And the second objective under this pillar is patient and our communities patients and our communities' comprehensive health needs are fully met. And so we were looking at, this is where we highlight the Change Institute and focusing on gaps in life expectancy, mitigating some of the social risk factors such as food or housing insecurity, and ensuring access again to treatments and advancements that are necessary. Finally, under this pillar, leveraging data, I think that was a good discussion we had in March using CCDPH data, and it really does help us as an overall system direct our attention to the issues that are reflected in that data. So optimization, systemization, and performance improvement is the next pillar, and that we're defining as optimize our systems to ensure they are accessible, reliable, appropriate, effective, standardized, and resilient. The first objective we have under that, I'm sorry, Director Guggenheim, it looks like I missed a question.
Yeah, I'm sorry to be so obtrusive today. Could we, when we highlight particular populations in the health equity, could we include people with disabilities? I feel that in my time as a director, I have failed to advocate specifically for people with disabilities, having been a sort of disability advocate at earlier points in my career. And I think we don't put enough stress on that because, I mean, this is a very large population, in fact, and staff do need specific training in order to be appropriate, I think. So I would like to include that along with LGBTQ, etc.
That sounds like a great idea. It looks like Director Ketting gave that a thumbs up as well. So we will definitely take that back to fold in.
And so do I. That's a
Please
great
take
idea.
care to use the appropriate language that we say people with disabilities, not disabled people. Okay, thank you.
Great, thank you for that comment. So under optimization, systemization, and performance improvement, the first objective is to standardize tools, processes, and procedures across the system. So some of the examples or some of the areas where we would see results are in geographic localization, in our referral and care processes, electronic ticketing and monitoring programs, and new contract and policy management systems. The second objective that we have under this pillar is implement performance and process improvement initiatives in both clinical and non-clinical areas. Having our call centers make patient access simple and available. And I had a formatting issue here. It's actually a separate one. This 5 and 10-year space utilization plans that help keep pace with infrastructure needs and ensure plant modernization. The CDI initiative in revenue cycle, the length of stay, and meeting benchmarks for length of stay, reducing the time to hire and procure, and ongoing process improvement work throughout that enhances our standard operating procedures. Finally, on this, to also impact agency and overtime utilization. The second objective under this pillar is create and sustain a culture of high reliability and transparency. So the areas that this would focus on are continuing the high reliability work groups that we've established, hardwiring some of the objectives identified in those work groups, looking to the future further out than this strategic plan for public health department, so that we have a longer term expectation of the direction we're going to go in with building out public health, establishing an Office of Life Sciences, and ensuring that compliance programs use the latest technology. So finally, our final pillar, well, I'll stop there and see, were there any questions on the optimization process improvement pillar? All right, I don't see any. For growth, innovation, and transformation, if you recall, the word disruption was in this when we proposed it in March, and we have taken that out based on feedback from the board. And this pillar is, we're describing it as leading the journey to effective care and better health outcomes through sound infrastructure and transformative access to care resources. So the first objective under this pillar is sound infrastructure and transformative access to care resources. And some of the results we identified here, executing timely on projects and enhancements in system and facilities and the facilities master plan, conducting appropriate preventative maintenance to extend the life of buildings and equipment, right-sizing our facilities to ensure maximum efficiency and throughput, establishing or having a comprehensive bed board and patient transfer center, expanding our surgical capacity and our care capacity overall, and conducting a community and health needs assessment to ensure that our facilities are available in underserved areas of the county. So looking at the second objective, it's use innovative products, services. Director Ketting, do you have a question?
Just a comment that the exhortation to remember that when we're dealing with facilities, we really have to have a long range view and can't get overly focused on what we need this year or 3 years, because if you invest in, for instance, the hospital, you're talking about 25 years, and we need to be looking at what are the longer term trends and let those inform our decisions and consider how we're going to feel about having that facility in a while. And in the same token, we need to remember that Strozier Hospital just passed its 20th anniversary of use. And for a hospital, that's getting into middle age, maybe even later middle age. So these are things we have to keep pretty square in our sites.
So it seems like your feedback might lead one to conclude here that 5 and 10 year space utilization plans are still a little short-sighted, that there should be a kind of a 25 year.
25 years is hopeless. I think 10 years is fine.
Okay.
If we're really thinking 10 years, but that really needs to take into consideration. It has to be kind of a dynamic view of things, not as a static view of things. And that's it's hard to do, but need to take into account what's happened to populations in the city and what's likely to happen to populations in the city, the age of the population, and then the age of some of the resources outside of our system, and how they're going to behave over time. So I mean, taking it out further than 10 years is useful, but I mean, you need to have it in mind, but it's not realistic.
Okay.
I think one of the things, I think that's really good feedback, and you're 100% correct, because time actually moves faster than we think, and we do a few of these, and we're not on the right course. It's hard to correct. What we can do to make sure that that's in our work plan is on the first bullet, when we say execute timely on all projects and enhancements in the system and long-range facilities master plan to better serve the patients. And we'll make sure that there is a long-range plan that looks at 10 and even out years of trends and industry trends that we should examine when we're evaluating the projects of today. I think that's a great feedback. Thank you.
Director Story looks like you have a question.
I did, Andrea, but Director Kettering, he's already covered the subject, and you and I have already had this conversation, so it would be redundant.
Okay.
Thank you.
Let me make sure
I think it's interesting, Andrea. I think it's interesting the building that you're in right now. To most of us, it's like that's still a brand new building, but it's how many years old now?
3.5 years, right?
Yeah.
Yeah.
I mean, yeah, we'll be knocking on 5 years, and it'll be like, it's relatively new.
I'll always think
Israel's
of it
point
as
is
a
well
new
taken.
building. Yeah. Are there any other questions or comments? Okay, I think this is where I was. So this objective, using innovative products, services, processes, and technology to lead the journey to effective care and better health outcomes. So some of the results we identified here include creating new care delivery programs, like trying to meet community need, establishing a mental health authority, which, as you all know, we've received an award from Cook County from the ARPA, the stimulus dollars, to help establish that. Also, developing a comprehensive Cook County healthcare network with other safety net providers, developing different products, such as the ones that are listed here, creating a learning collaborative with community-based organizations, and modernizing technology at CCH. Director Guggenheim?
Yes, what in fact does establishing a mental health authority mean? I mean, that sounds like a governmental entity, a mental health authority. We don't have jurisdiction over that. Do we?
Yeah, and I think, we're still kind of talking about what it should be called, but it's conceived as really building out our mental health, behavioral health footprint throughout the county. That, we do have some programs. We have, psychiatrists, psychologists, social workers, and, a lot of the feedback we've been getting is that it's not enough.
To say a
And
mental health authority sounds like a 708 board or something like. I mean, we can't do that, can we? I mean,
yeah, it does sound like a taxing entity. And actually, just yesterday, Israel and I were talking about that word, and I think the authority we might take that word and replace it with office, or some other more neutral.
Or increased capacity or something,
Yeah.
So it actually, so I want to be clear about that. It actually is a little bit more than just increased capacity. And to answer your question, it's one of the pillars that we're working with Cook County on in partnership with ARPA. And so what the Mental Health Authority Initiative is, and we'll maybe put initiative, is that when we look at our county, we're one of the largest counties in the United States that doesn't really have a mental health authority, helping to coordinate it in the local area. So exceeding 5 million is one of the areas that we have individual institutions, but not really a government actor like a public health department or something similar that's really looking at how our mental health, just specifically on mental health, how they're coordinated across both the city, county, and area. So this isn't just the providership of care, it is looking strategically how we can start to convene a organization as part of our public health and our overall county health goals of looking at how we can better serve, coordinate, and provide support to the overall spectrum of mental health in our county, and how we can be strategic in supporting our partners and community partners and even other providers in expanding that. So this actually is a little more than just, we will look at, of course, our behavioral health services, but this is sort of an independent space we want to bring for collaboration, and it could lead to other things in the future. I don't know what it is, but you're right to say that its authority now is a little premature, so we can say initiative or department, but it is meant to be sort of separate. It will be much more community expansive, and it's part of what we got under ARPA to respond to the community needs of ensuring that mental health and the coordination of health services was taking place in our county, in our communities.
Yes, I'm really grateful, Israel, that you're giving me such detailed answers, but I'm having a huge problem actually hearing you today because the audit piece is sort of difficult. It seems to me there's always a bit of a paradox about this business. We want to increase capacity to respond to people's mental health needs, but we want to keep it integrated with general physical health. And I mean, what one wants is that first line providers, I mean, primary care providers, are competent to sort of recognize and diagnose when people have mental health problems and then have sufficient referral systems to actually carry on with treatments. So it's how it's phrased seems to be enormously important in how philosophically you're dealing with this question.
No, I agree. Can you hear me a little bit better now? I got a little closer to the mic.
And launch new clinical education, training, and research programs, as well as innovative strategies for justice-involved patients, and create new public health programs that increase patient engagement and expanded data sharing. So that's kind of my very quick run through of the pillars we're proposing, and we got some good feedback already. You know, we're certainly open to any additional feedback now, or if you want to get back to us separately by May 13th, so that we can present a final strategic plan to the board at the end of May. With that, I'll stop and see if there are any additional questions. Chair Taylor, I don't see any hands up.
I don't as well. Thank you very much for the detailed, follow-up, comprehensive overview. I'd ask each of you, each of the directors, as you review this and reflect, to please revert back in writing or however you think best to reach out to Andrea and Israel to share any additional thoughts or feedback as you reflect and review, and reflect. At this point, I think next on our item, the board will now be going into closed session. Action is anticipated to be taken in open session after the closed meeting has adjourned. I'd like to entertain a motion to go into a closed meeting pursuant to the following exceptions to the Open Meetings Act. 5 ILCS 120/2C 1, 2, 11, 12, 17, and 29. Do I have a motion?
So moved.
So moved. Second.
The motion has been made and seconded. Madam Secretary, please take the roll call vote on the motion.
Roll call vote on the motion to go into closed session. Aye or nay? Director Curry?
Aye.
Vice Chair Deere?
Aye.
Director Garza?
Aye.
Director Guggenheim?
Aye.
Director Harrington is absent. Director Kim is absent. Director Kedden?
Aye.
Director Munar? Director Munar? Is absent. Director Prendergast? Is absent. Director Ryder?
Aye.
Director Story?
Aye.
And Chair Taylor.
Aye.
So you have 8 yeas and 4 absent.
The ayes have it. The motion carries. We will now go into closed session. Thank you.